itself with the pressure drop. And so not only we say there is a soft tissue plaque here, but the soft tissue plaque is associated with a hemodynamic impairment that deserves to be treated. Another example, 60-year-old male with stuttering angina. You see we have a lesion here on this vessel, left anterior descending artery. Basically, visually, I would say this is something between 60 to 70%, but I'm not sure. We can do FFR here with, again, sending the images to the United States, so it's still a complex procedure. In a couple of hours, we get this colorimetric map, which tells us that this lesion is associated with a pressure drop of 0.75. So the threshold is 0.8. This has to be treated because there is ischemia of this level. It is extremely accurate, existing already since 10 to 15 years, and more it is moving to, let's say, an arena of clinical application. For example, here we use it in heavily calcified vessel. This is published in JACC Cardiovascular Imaging 2015. So when we have highly calcified lesion, FFR improves the accuracy of cardiac CT and allows a better risk stratification. This is the third option we have, is post-processing. The second option is myocardial perfusion. What is possible and how can we stress the heart in cardiac CT or MR or in any other tool? Imagine that we have a 50 to 85% stenosis here. In rest condition, the myocardial blood flow is preserved here and here. By dilating the vessel, we basically activate the so-called coronary steal effect, meaning that the direction of the flow is predominantly in the normal vessel, and here we see a cold spot, a dark area that is perceived as a perfusion defect. This is what we do in clinical practice and is used, for example, in cardiac MR. But the same concept can also be adopted in cardiac CT. We use different stressors from dipyridamole to adenosine, brigadenosone. I wouldn't go too much into detail, but basically the principle is to activate beta receptors in the heart, increase contractility, increase dilation of the heart and of the coronaries, and activate the stealing effect. Let me make it a little more practical. Maybe I'll skip this and show you how does it work practically. Sorry, I'm skipping it. Look here, this is exactly an example of dynamic perfusion with CT. So contrast arises from the right to the left ventricle. We look at contrast distribution from the left ventricular cavity to the myocardium, dynamically plot this image, obtaining an arterial input function and a myocardial input function, and we finally get a colorimetric or perfusion map, which is directly influenced by the amount of iodine. So what can we do here is to measure the amount of iodine and look whether a lesion is associated with ischemia, and so if the concentration of iodine is reduced and if myocardial blood flow is reduced here. One example from our clinical practice here, showing rest versus stress cardiac CT in a patient with a coronary artery bypass. You see here there is a huge dark area that I'm showing you here in stress, clearly being an ischemic area, and this area is basically almost not observed in rest condition. So when we stress the heart, we trigger perfusion defect, and this tells us that this region is suffering of ischemic heart disease and deserves to be treated. And this is extremely fascinating. And I think in my institution, I work in the largest or one of the largest cardiological hospitals in Italy. We are using CT perfusion. This is from my colleague Gianluca Montone, who was wondering, are we ready for the green light? Yes, I think combining CT angiography and myocardial perfusion is something that deserves a lot of attention. Finally, coming to a little more advanced topic that I think is of great interest I told you that cardiac CT is really the new tool for stable chest pain. We can look at plaque imaging, we can look at the degree of stenosis, we move to perfusion and FFR, fractional flow reserve, to look at ischemic heart disease. And I think the new frontier, like we do for TAVI planning, like we do for endoprosthesis, like we do in any other field, is to use CT for prediction of coronary vascularization and pre-procedural plan. Basically, how does it work and what am I talking about? Look at this sort of pyramid, which basically tells us what should be done in different clinical scenarios. Imagine that the patient has no coronary artery disease. I think our task is finished. Or imagine a patient having non-obstructive coronary artery disease. So a lesion of 20, 30%, which doesn't need to be stented. Here, we can activate primary prevention and medical treatment. But if we are moving from a single vessel or two vessel disease in a coronary artery disease patient, we can think of doing an angiography, we can plan stenting, etc., and more we move to patients with three vessels positively affected, in which the dichotomy is between CABG, coronary artery bypass surgery versus PCI. What are we trying to do more and more is not only to use CTA as a diagnostic tool, which is accepted, but to fill the gap between the angiography and the stent placement and the CT examination. Just let me show you some example. Today, a really new concept, a new philosophy is this so-called CT-guided PCI, which is percutaneous coronary angioplasty. With CT images, we can drive the treatment planning, we can drive the online PCI guidance, and we can prepare the procedure itself. One example that I think is extremely interesting regards the calcifications. I told you calcifications are the enemy of CT, but this is also very important if the cardiologist has to play a stent. We can look at the thickness of the calcifications, and this is, of course, can be a problem for stent placement. We can describe if calcifications are circumferential or not circumferential, and we can match our images with what is called intravascular ultrasound, which is the ultrasound of the vessels predicting what is happening at the level of the vessel themselves. And this is extremely important because the amount and the features of calcifications are predictors of procedural success. Let me show you something from our experience from our hospital. By using artificial intelligence tools, we can create a three-dimensional model of the coronary artery. We can measure features like what is the degree of the ostium, how are the calcifications distributed, are they long, are they short, and basically how can I treat this lesion, which kind of stent would I better place to have an optimal procedural success. So I don't want to be too much complicated in this, which aims to be, let's say, a basic or introductory lecture to coronary CT angiography, but for those of you who might be interested, this is by far the most attractive or one of the most attractive fields of radiology, and more we are moving to planning of the procedure, which is fascinating. So an overview of what we can do, we can look at anatomy, we can localize the lesion, we can look at plaque composition, we can measure ischemia, we can look at the projections for angiography, and so on and so on. And this is something that is done in clinical practice. So why should we do CT angiography in patients with stable angina? And why is it today the gold standard and the first tool according to clinical guidelines? Firstly, CT perfusion and CT angiography is comparable, is not superior to SPECT, and this is something that gives us a strong value. We are dealing with a high negative and high positive predictive value tool, so exclusion of coronary artery disease is approximately 100%. We can combine anatomy and function we can look at we can work with acceptable radiation doses, and this is something that really deserves a lot of attention. So I was asked to talk about half an hour, and my chronometer tells me that I'm on time. It has been a pleasure, and I'm open for discussion. I'm receiving some questions as far as I see, so I'm available for the discussion. And thank you so much for this opportunity.
Thank you, Professor. Thank you very much. So we have one question from Mustafa Shihabi asking about is still IVUS used to quantify plaque burden or not used anymore, as cardiac SPECT-CT is now part of the past? What do you think?
So I would say today cardiology has changed in terms that SPECT and nuclear medicine is less and less used for two reasons. Firstly, SPECT does not provide information about coronary anatomy, and so CT is preferred for that. And secondly, the resolution, the spatial resolution of SPECT is not comparable to cardiac CT, and this is another limitation because I mean we don't see, for example, subendocardial perfusion defects, and this is a problem. Regarding the use of intravascular ultrasound, our cardiologists are still using it, but it's extremely costly and it is invasive because basically with intravascular ultrasound, you use a probe which is a single use, costs about $3,000 to $5,000, and you get informations that are almost or comparable to cardiac CT.
Yeah. So yeah, I have a question from my side. Yeah, I tried to do my CT myocardial perfusion. The radiation dose was almost as much as radiation polytrauma CT. So how we can overcome this high radiation dose for that?
I think right now the radiation is much higher than, of course, than the simple CT angiography. Today, I don't have a photon counting scanner. We are installing it, but what I've read with photon counting with new technology, we can get excellent signal to noise ratio and work with 70 kilovolts. So I guess the radiation dose will go low. On the other side, if you think of the advantages of getting ischemic information, I think it's something we are using in positive patients. So what we do is to firstly do the angio, we look at the coronaries, and if the lesion is bad, and of course patient's age and a series of other information are not really at risk of delivering a high radiation dose, we go for perfusion. But I agree, this is still non-optimal.
So this is, I think, related to the question from Dr. William Mallah. He's asking whether CTA can replace cardiac MRI and for the use of stress perfusion.
Honestly, I'm also an MR fan. At the moment, they have two different fields or two different areas of interest. Cardiac MRI is the best because it's non-invasive. It combines viability study, etc. So at the moment, to say something, I would say no. It will combine anatomy and function. So it's a different field of application. They're not competitors.
Okay. So, and then Dr. Anis is asking whether Tri-Smith score and stress spectro can be enough to determine the significant disease, or you still need